Hi, I'm Mike Lloyd of the Digital Education Committee for the Heart Rhythm Society. I'm super excited today because we are launching a new digital education project. The lead has been really popular. It helps people. It's kind of like a journal club, but it's one article at a time. And so I'm excited now to present a supplement to that. And that is the EP-Edge Heart Rhythm Society collaboration. This is more of a broader look at the wealth of data that comes out every month in terms of a clinical question. So with me today is Dr. Niraj Sharma. He's the creator of EP-Edge, is going to talk to us about what this was all about, how did you start it, and what was your reasoning behind it?
Right. Thank you, Mike. It's a pleasure to be here. Thank you to start this new pathway, new journey with this collaboration with HRS. So what really happened was started about a year or so ago. And at that time, I started really seriously looking into how many articles are presented or come out. And we found there's a huge literature that's being pumped out pretty much every month by different journals. And not only is the amount huge, the number of articles that are coming out at a much faster pace than we ever had before.
Right.
So there's this lack of adequate curation of these articles. Now you have these AI algorithms that actually pull up the most cited, the most viewed, but really you need a human curating this to a large extent to determine which of these articles that are coming out are actually clinically meaningful or not.
Well, talk to me about where this is out now. And what kind of followers or who's following? Is it EP doctors? Is it PAs?
Right. So yeah, this whole EP-Edge Journal Watch concept started off with a newsletter.
Okay.
So the newsletter comes out first, and this newsletter comes out in really essentially two forms. One would be LinkedIn, the other one is Substack. And tracking these subscribers or how many people are following these newsletters, majority are electrophysiologists, followed by cardiologists. Then you have residents and fellows, and then industry and other people that have an interest in electrophysiology. So the response has been very encouraging, not only in terms of how many people are actually reading, you can track if they're actually reading the article or not, and also about the number of downloads we've had on our podcast. So over the last 5 months, if you were to ask me, it's grown about 600-700%. That much. Huge growth.
So give me an idea of the numbers for downloads you have.
The numbers, we can get the number of downloads, but what's difficult to get is the true number of subscribers.
Yeah.
Because what happens is these podcasts go through this distributor, and distributor distributes it wherever. So the data that we get in terms of downloads per month, it's about, I would say for the EP-Edge, we have 2 podcasts, but the EP-Edge Journal Watch specifically is about 1,000.
Wow. That's great. That's wonderful. I heard you mention about AI and why would somebody not be able to just kind of look, ask, open evidence, what's the last 5 journals? Why do you need a human being to curate this stuff?
That's actually, that's a really good question. I think about this quite often, and I've actually tried this out, and a lot of people have tried out. When you use PubMed, for example, or open evidence does scan journals, but when it does scan, it does not really pull out the clinically most meaningful articles that are out there. It would give you the top list or what the new guidelines say. But if you were to ask it, okay, tell me, for example, if I don't have access to IV ibutylite or IV procainamide for a pre-excited tachycardia, can I use amiodarone or not? Now, this applies to a global population, not necessarily in the US. So if you're in Latin America or India, what can I do? Can I give amiodarone safely or not? That's not going to be picked up because it just came out maybe 2 months ago and is deeply buried in literature.
Right.
And I could give you so many other, I'll give you another example of a situation where you have potentially higher risk for a device infection occurring for potentially a generator change. And you don't have access to an antibacterial pouch. Which antibacterial irrigant can you use? So there's a trial out there that says chlorhexidine is equivalent to an antibacterial pouch. So it's articles like this that really don't make the top 10, but they're
So
clinically relevant.
not the most sexy topics, but very relevant everyday stuff.
Practice changing.
Yeah.
And the whole concept behind EP Edge is not only is it practical, it has to be concise, because we know all of us are so busy. We hardly have any time to scan through journals. Some of us have no time at all.
Right.
So the thought was to try and get this podcast done in 15, 20 minutes. Now, some episodes are I wouldn't say less, majority a little bit more than that, because there's so much literature out there.
So what can our HRS members expect with this collaboration? Once a month, tell me what do they turn it on their commute?
Right, they should. So I think this is a great collaboration. HRS is a global organization with a huge outreach. It's not only American, you have followers in India, Africa, Latin America, Europe. It's a global phenomenon. What EP Edge brings to HRS is the filter, the analysis, and the practical analysis of these trials, and a huge exposure that HRS would give this format.
So it's kind of like an audible journal watch, but also with some input by you or whoever the commentator is, and putting it into some sort of clinical perspective.
Right. So the way we are going to try this is the EPA Journal Watch will continue to come out with these trial analysis every week.
Right.
The fourth week would be a discussion of some relevant trials that were already covered, but a more discussion of these trials that would occur at, I guess, the fourth episode.
Wonderful. So with that, are you ready to start our inaugural episode?
Yeah, let's do that. I guess the biggest trial that was occurred today was the AVANT trial.
Let's do it.
Yeah. So let's talk
Ladies and gentlemen, it's my privilege and honor to kick off the inaugural episode in EP Edge collaboration with HRS. Our discussant is Dr. Niraj Sharma. So let's get into it. Let's talk about avant-garde.
So the avant-garde trial was, I think, presented about 6 hours ago in our late breaker session at HRS, and was simultaneously published in the New England Journal. So when I came out of the trial looking at the presentation, I thought, well, this is a good trial. This would be a good trial for our patients. A lot of our persistent A-Fib patients, their trial on medications first, and if they have to fail antiarrhythmics before they get an ablation. But this trial actually did something really interesting. It was a first of its kind, and all credit to the authors for doing this trial. What they did was they took patients with persistent atrial fibrillation, standard definition, not long-standing persistent, but persistent A-Fib less than a year. And they had never been on an antiarrhythmic drug, so de novo drug-naive patients, and then they randomized them into an ablation PFA, Ferropulse arm, and antiarrhythmic drug arm. So there's two interesting points that I kind of realized when I read through the article. Now, I need to read that article a few more times to get a better gist of what really happened. But
well, in fairness, it just came out. I mean, this is hot off the presses.
It is hot, and it's so much to digest.
Right.
And you're absolutely right. The slides that I saw, there's far more beyond the slides that were disclosed today. So what I found was, and this was in the presentation too, that in October, I believe in 2024, I'm not really sure the exact date, but the trial had to be halted. And the reason it was halted because there was an increased number of strokes. And they had a detailed analysis to why these strokes occurred. I guess 1 out of the 6 was because of air embolism, sheath management issues. These strokes were minor. They all made full recovery, but the Data and Safety Board had an analysis of the enrollment criteria, and they made some changes to the enrollment criteria. And this occurred later on in the trial. So majority of the patients were already enrolled in the initial criteria, and I guess a smaller proportion were enrolled in the modified criteria. And the criteria was, okay, we're not going to take patients who have a CHA2DS2-VASc more equal to or more than 4, They had to be on anticoagulation continuously for 4 weeks prior to ablation. A TE was needed to rule out clots. The ACT had to be more than 350 during the procedure or before ablation started. So all those criteria were placed in the second part of the trial. So it becomes difficult, at least in my mind, to try and equate this as one large trial. Then looking at the methodology, there was a new feature that was added on, which has previously never been done, and so it becomes difficult for us to kind of compare trials. And what they found was asymptomatic. This is the criteria that was added on. Asymptomatic episodes of A-Fib lasting for more than an hour, equal to or more than an hour, were included as an endpoint.
Okay.
Okay, so this was new, and of course, A-Fib more than equal to 30 seconds or more, the standard criteria was in there. So the result was, if you look at the two arms, the pulse field ablation versus the antiarrhythmic, if you look at the classic success rate, A-Fib equal to more than 30 seconds was equivalent, was the same in the two arms. So, but what was different was the asymptomatic episodes in the ablation arm went significantly down.
Right.
So I guess more analysis needs to be done, but those was my two important takes on the avant-garde.
There's a lot of buzz about atrial appendage management, atrial appendage management. Some has come out here, but really in the last 2 months, 3 months. Talk to me about those trials.
Yeah, you're right. March 2026, two big trials came out. Same journal, New England Journal. Both looked at what peripherally, superficially looks like essentially the same concept, but totally different trials. Both were trying to answer this question about, can we get rid of anticoagulation, and is a left atrial appendage closure device enough? So one was the Closure AF trial, which was done in Germany. It was a German trial. And then the Champion AF trial, which was a multi-center, multinational trial. A lot of differences between the two trials, but one of the key differences was the patient selection. In the Closure AF trial, there were really sick patients. So the Hasbler score was 3+, the Chart-VAS score was really high. So it was a classic group of patients that we would be hesitant to give them long-term anticoagulation.
Right.
So that trial turned out to be non-inferior. So meaning left atrial appendage closure devices offered no additional benefit to anticoagulants.
Not non-inferior.
Not non-inferior.
Yeah, it's a hard concept to wrap my head around. The trial differences also funding. I mean, one was industry, one was not.
Correct. So that's true. I don't know how much weight you can give to that, but that's true. The Champion was funded by a vendor, and the Closure AF was not.
Yeah.
So there was clearly maybe not. There was bias, but clearly that's one issue. But the Champion trial included patients where currently you and I would not really think of taking them off anticoagulation. They were lower Hasbler score, low Chart-VAS score, really a person who's doing well. So they included a different, relatively healthy population. And it's interesting, Mike, that both these two trials, what drove not inferior or non-inferior to was bleeding. So in the Closure AF, there was high peri-procedural bleeding. Now, in the Champion AF trial, they did not include peri-procedural bleeding.
Right, that was
separate.
Part, yeah.
That was part not of the primary cohort, but of the secondary analysis. So if you included that into the primary analysis, then it wouldn't be not non-inferior. So, and also the other issue is the clinically relevant non-major bleeding. That was another issue with the Champion trial. If you incorporated that too, it again would be not inferior. So
put it into some clinical perspective then. Are you going to start offering appendage occlusion to people as a viable alternative to anticoagulation, or should we reserve it for people who have a problem with anticoagulation?
Right. So yeah, Mike, that's a really good question. Based on these two trials, and it's really important to interpret these trials in the context of patients that were actually studied. So the patients that truly need to be off anticoagulation, the frail, elderly, high HAS-bled, the closure AF trial said no.
Right.
Right. So it's a conundrum that we're in, right? So if your institution and your own data set says that your complication, the peri-procedural complication rate in that subset of patients is good, then maybe you should. But it really boils down to what your complication rate and what the shared decision is that you have with the patient.
Okay, I'm going to put you on the spot, and we've talked about this in our journal clubs. The summation of closure and champion, is this a strike against or a victory for atrial appendage? Strike against or victory for?
I think it's the status quo. It's the status quo.
Good neutral answer.
Yeah, it's the status quo. And I think that is the honest answer.
Right.
I don't think the champion changes anything.
Right.
I think the closure does put caution in my mind.
I want to talk about one final thing before we wrap it up, and that is, what about the idea of just stopping the blood thinners after a while? They're doing well.
Yeah.
Put that into some perspective. Maybe
Right.
Ocean.
Yeah. So last year, we had two trials that came out pretty close to each other. The Ocean trial and the Alone AF trial. Now, both these trials, so the Alone AF was a Korean trial, and the Ocean was actually a Canadian trial with multi-site enrollment. So the concept in both these trials, however, was the same. They said, well, in low or intermediate risk score, CHA2DS2-VASc score of around 2 or slightly more than 2, patients that have had apparently a successful ablation, AF ablation, can we stop their anticoagulation?
Right.
What happened in the Ocean trial? The trial was stopped prematurely because the number of instances of stroke were so low, and the bleeding risk was high. So it was felt, well, we'll never meet our endpoint, so the trial was stopped. But it showed us the fact that when you do an ablation in low risk, low CHA2DS2-VASc score, and you have a successful ablation, our monitoring becomes really important. How you monitor? Do you do a loop recorder? And in fact, which loop recorder to use, that's another discussion. But in these trials, there was no loop recorder implantation, so it was intermittent monitoring. So in that trial, the bleeding risk in rivaroxaban was the drug, was the DOAC that was used, was higher, and the stroke risk was low. And it suggested maybe, after again a shared decision, in these low risk population of stroke who have apparently a successful ablation, you could consider it. And the Alone did the same, although the Alone trial went all the way to completion, but the results were essentially the same, meaning that the bleeding risk was far more than the stroke risk. So the balance was more bleeding. Do you want to take more bleeding versus a very lower risk for stroke?
Very low risk of stroke. Does that hurt you cognitively?
So that's the trial that was presented yesterday, the Alone AF sub-study looking at cognitive decline. And that study was actually a really interesting study. Of course, the cohort was the same patients that were in the parent Alone AF trial. But what it showed was it made no difference cognitive-wise whether you were on anticoagulation or not. But what it did show, surprisingly, in a sub-analysis of this trial was that if you were in sinus rhythm, it did reduce your cognitive decline. So maintaining sinus rhythm had a benefit. So maybe another trial.
Maybe not the drug, but the rhythm.
The rhythm, exactly. Exactly.
We can expect every month a distillation of Dr. Sharma's content on EP-Edge through HRS EP-Edge collaboration. Look for it in our podcasts along with the lead. And Niraj, thank you. I'm excited to keep this going.
Absolutely. Great pleasure. Thank you.